What is the most likely diagnosis? Alopecia areata, hypothyroidism, lupus erythematosus, seborrheic dermatitis, trichotillomania. A 16-year-old girl presented with non-scaly discrete areas of hair loss on the scalp. She had a history of atopic eczema and a number of depigmented areas on her hands and around her eyes. What is the most likely diagnosis?
This young girl presented with non-scaly discrete areas of hair loss on the scalp. She had a history of atopic eczema and had a number of depigmented areas on her hands and around her eyes. Atopic eczema is an autoimmune condition, and also the evidence of depigmentation most likely points towards the vitiligo. Vitiligo, an autoimmune condition which results in the loss of melanocyte and consequent depigmentation of the skin, which produces white patches on the skin, often symmetrical. Symmetrical presentation is the cardinal features of vitiligo. Vitiligo associated conditions are the autoimmune disorders like type 1 diabetes mellitus, Addison's disease, autoimmune thyroid disorders like Graves' disease, pernicious anemia, alopecia areata. In your Mrcp exam, whenever they give you a history of one autoimmune condition, most likely the answer would also be an autoimmune disorder. But before delving into the final diagnosis, let's discuss the fact of scarring versus non-scarring alopecia. Scarring alopecia is associated with destruction of the hair follicle. Scarring alopecia is most commonly seen in case of lichen planus, discoid lupus erythematosus (DLE), which is the cutaneous manifestation of SLE, as well as untreated tinea capitis. Non-scarring alopecia is associated with preservation of the hair follicle. Alopecia areata is usually the most common cause of non-scarring alopecia, which is an autoimmune condition. Other causes of non-scarring alopecia include telogen effluvium, trichotillomania, drugs, nutritional disorders like iron and zinc deficiency. Alopecia areata is a presumed autoimmune condition causing localized, well-demarcated patches of hair loss. At the edge of the hair loss, there may be small broken exclamation mark hairs. This is the pictorial of a patient with alopecia areata. You can see non-scarring, localized, well-demarcated patches of hair loss. There is no features of scarring, and also there is well demarcated margin. Non-scarring, localized, well demarcated patches of hair loss. This is the dermoscopic image of alopecia areata presenting with exclamation mark hairs. You can see the short exclamation mark hairs. Patches of smooth, non-scarring hair loss. Smooth and no evidence of scarring. Autoimmune association. And these are the short exclamation mark hairs. We may also get the evidence of hyperkeratotic plaques and black dots, which usually result from destruction of the hair follicle. Hypothyroidism is usually associated with diffuse hair thinning, which may ultimately involve the entire scalp. Hypothyroidism does not present with discrete areas of hair loss. Both hypothyroidism and hyperthyroidism may trigger the telogen effluvium. Effluvium means abnormal hair shedding, which may occur during the telogen or anagen phase of the hair cycle. Telogen means shedding, anagen means growth. Telogen effluvium is the most common cause of diffuse hair shedding. A triggering event usually leads to increased number of anagen hairs to prematurely enter the catagen and the telogen phase. Patients usually experience clumps of hair falling out on their hairbrush or while taking the shower. The excess hair shedding may produce diffuse thinning, bitemporal recession, or ultimately involves the entire scalp. This is the pictorial of a patient with telogen effluvium. This patient has presented with diffuse hair thinning leading to bitemporal recession. This is another pictorial with the telogen effluvium. You can see the diffuse hair thinning. Hair brushings during episode of telogen effluvium. You can see the excessive hair fall. Patient with hypothyroidism will also present with the clinical features of weight gain, constipation, cold intolerance, and hypertension. The absence of clinical presentation is also making hypothyroidism unlikely. Lupus erythematosus may present with DLE, discoid lupus erythematosus, which is always associated with scarring alopecia. DLE is a chronic scarring skin condition and the most common form of cutaneous lupus. Lupus scarring hair loss is characterized by the development of discoid, meaning cone-shaped patches of permanent scarring. This is the pictorial of a patient with scarring alopecia due to discoid lupus erythematosus. You can easily see the evidence of scarring alopecia. Evidence of scarring, manifestation of a lupus hair loss evidenced by scarring. This is also a pictorial with discoid lupus, which is demonstrating scarring hair loss, evidence of scale and erythema. Lupus erythematosus will also present with active inflammation as well as photosensitive rash rather than depigmentation. Seborrheic dermatitis is a dandruff-associated condition leading to diffuse scaling on the scalp without hair loss. Seborrheic dermatitis is a chronic or relapsing form of dermatitis which mainly affects the sebaceous glandrous regions of the scalp, face and trunk. And diffuse scaling is the cardinal feature of seborrheic dermatitis. Seborrheic dermatitis is most commonly seen in a patient with HIV or Parkinson's disease. An itchy rash affecting the face and scalp distribution is commonly caused by seborrheic dermatitis, which is characterized by greasy erythematous rash and has a fine scale over the face affecting the cheeks, nasolabial folds, eyebrows, nasal bridge and scalp. This is the pictorial of a patient with seborrheic dermatitis, presence of diffuse scale involving the face. This is another pictorial of a patient with seborrheic dermatitis. You can see the evidence of scale or dandruff. You can see the evidence of diffuse scale or dandruff. The non-scaly presentation along with the features of hair loss is virtually excluding the seborrheic dermatitis. Trichotillomania, which is also known as the hair pulling disorder. Tricho means hair, tillo means pulling, mania refers to psychiatric association. Trichotillomania is a psychiatric disorder characterized by recurrent irresistible urge to remove or pull one's own hair, especially from the scalp, eyebrows and eyelids, which will ultimately lead to alopecia. This is a pictorial of a patient affected with trichotillomania. Trichotillomania is always associated with psychiatric disorder rather than autoimmune disorder. So finally, patient presenting with non-scarring or non-scaly type of alopecia associated with a history of autoimmune disorder like atopic eczema and vitiligo, the most likely diagnosis is alopecia areata. And as a shortcut rule for your exam, history of atopic eczema with or without vitiligo is most commonly associated with alopecia areata. A for atopic eczema, A for alopecia areata. Alopecia areata option A is an immunologically based disorder where there are discrete areas of hair loss but without scarring or scaling, and patients with this condition have a higher incidence of atopic eczema. Hence, option A is correct. In lupus erythematosus, there is usually active inflammation with scarring, whereas in trichotillomania, there are residual short hairs at the affected site, frequently of the same length, because the patient generally finds it difficult to pull the shorter newly growing hairs. Hypothyroidism can give patchy hair thinning with brittle, straw-like hair and bald patches, along with the other symptoms of hypothyroidism, such as weight gain and constipation. Seborrheic dermatitis generally gives diffuse scaling on the scalp without hair loss. Although it can cause some areas of hair loss, this would be associated with scaling of the scalp.